Okay, this next lecture is only going to be about 10 minutes or so. Just a quick discussion of this new concept called delayed sequence intubation. And basically, this falls into our not difficult arm. So the patient is not predicted to be difficult, but their SATs are less than 94. Why? Usually because they're combative and won't cooperate with us when we're trying to pre-oxygenate them. So remember this graph here and this steep fallout curve. Well, what if you were to start at 87%? You know, your graph is going to look like this. You're going to desaturate extremely rapidly. So what we want to try to do is at least improve our chances, get them up to 94% or better, and extend that apnea time by at least a minute or so that we've got more time to place the tube. So our goals are we want to, we know that once we paralyze the patient, they're likely to start getting hypoxic, even though we have the passive oxygenation. And we want to avoid the use of the bag valve mask after paralysis. And this is a kind of a running fight I have with my RTs. After the paralytic is administered, they want to get in there and start bagging the patient. And I have to knock the bag valve mask out of the way because we don't want to bag the patient once we take away their protection for aspiration, because we're just going to basically fill up the stomach, and that gastric distension may erupt into vomit, which is going to complicate intubation and may result in long-term aspiration problems. So we want to avoid that. So we want to get them as high as we can before we paralyze them. Once we paralyze them, no more positive pressure ventilation. Gastric distension and aspiration is what we want to avoid. So this is, the science behind this isn't that great, but kind of this could be published in the Journal of Duh. If the patient is hypoxic when you start, they're going to get hypoxic much faster than if their oxygen is normal when you start. So this study, the breakpoint was 94%, and that's what Scott Weingart used when he initially started talking about this. So we expect continued desaturation from the moment of paralysis onward. So we talked about this already. So in terms of pre-oxygenation, what can we do in the emergency department to maximize the oxygen saturations before we paralyze them? So Muazzam, is that how you pronounce that? So what technique can we use in the ED to try to maximize their oxygenation before we paralyze them? So non-rebreather mask on there. Now, is a non-rebreather, is that an FiO2 of 100? No, it's like what? Yeah, 60, 70%. Why? Because they're rebreathing some of their exhaled air. So one option would be to take a bag valve mask in a cooperative patient and put that on them and just have them breathe on the bag valve mask. How long do we need to have them on there to maximally oxygenate them? What's that? So if they're taking, so 3 minutes if they're just taking normal breaths. If their vital capacity, it's 8 breaths. Or if they're unconscious, and we're bagging them, it's 8 bag valve masks. So the magic number is 8 or 3 minutes. 3 minutes, after 3 minutes, you don't get any additional value on an FiO2 of 100%. This 8 breaths is important because what happens when you go on your first attempt and you don't see it? The SATs are dropping. Now the SATs, you start bagging and the SATs are 75%. And there's always 2 or 3 nurses going 75%, 74%. 73%, and so you keep bagging and bagging and bagging until 91%, 93%, 95%. Well, now you're 16 breaths into it. So the one important thing is the pulse ox is data from how long ago? Yeah, 30 seconds to a minute. This is basically old data that's not helpful now. So if you know that 8 breaths is the best it's going to get, you tell your RT to deliver 8 breaths. At the end of the 8th breath, regardless of what the SAT is, you're going back in for your second attempt. And weird, as you're doing your attempt, the SATs are coming up because, again, it's measuring what the saturation was 30 seconds to a minute ago.
What if it continues? I mean, I agree with you. I think physiology, it's going to go up. But the problem sometimes is it's going to continue to go down. And then anesthesia, when you do the QA, it's like, well, you didn't really pre-bag that patient well enough. That's you start off with a losing battle.
Yeah, and so that's where now you're wondering, are you in a failed airway? Because you expect the SATs to drop during your intubation attempt. You don't wait for them to come back up before your second attempt. But if your second attempt you can't get the tube, and wow, the SATs really never came up, well, wait a minute, now I'm probably in a failed airway. I can't intubate and I can't ventilate, so now I'm going to go either to the surgical airway or the supraglottic device. But yeah, sometimes it never really comes up that high. And sometimes, it's not reading well because they're so peripherally clamped down, so, the ear probe or the nose probe. So, but, the nurses and the staff get so caught up in that pulse ox. We'll talk about a case when we talk about closed cases from MedAmerica Mutual, where I think a CP partner successfully intubated 3 times and 3 times pulled the tube out because the sats were dropping immediately post-intubation. Okay, so pre-oxygenation, we also have the option of BiPAP and the super high flow nasal cannula that I showed you guys. So these are options for the cooperative patient, but for the uncooperative patient, they're just not going along with the program, so they need to be intubated. They're not playing along with us, and so this is the patient where we do this delayed sequence intubation. So ketamine is the drug of choice. We give 1 mg per kg, which is essentially our induction dose. You can repeat it 0.5 mg per kg, but usually you don't because this is only a 3-minute process. So about 10 or 15 seconds after the ketamine has been administered, then you put them on BiPAP or super high flow nasal cannula or even bag them. You let it go 3 minutes, and whatever the SAT is, you stop it at 3 minutes. But the prediction is that you're going to get above 94% or higher with effective ventilation for 3 minutes. So after 3 minutes, you're going to, and so one option here is either the high flow or the BiPAP. Then after 3 minutes, now you administer your rocuronium and you complete intubation. Okay? So here it is one more time. You got the patient that's predicted not to be difficult, but you can't get their SATs up. You sedate them with ketamine. You wait. You put them on BiPAP or high flow nasal cannula or bag them. You do that for 3 minutes. Then you give your rocuronium, and then you intubate.